Welcome to the Executive Innovation Show podcast, where we bring you real executive conversations with industry game changers and thought leaders. We ask the questions you're thinking, what you're scared to ask, and we make your brain hurt afterward. With your host, Carrie Chitsey Wells, co-founder and CEO of One Touch Video Chat, live video interviews, and the nonprofit Humans Helping Humans.
Hello, everybody, and welcome to today's podcast of the Executive Innovation Show, brought to you by One Touch Telehealth. We're going to be talking about chronic disease management and palliative care, virtual care versus hospice care. We're going to be talking to Dr. Kuebler, who's the founder and director of Multiple Chronic Conditions Resource Center, highlighted by the U.S. Department of Health and Human Services for providing resources to improve patient care for the largest and fastest growing U.S. population. She's award-winning author of 8 textbooks, multiple peer-reviewed publications in chronic care and palliative care. Dr. Kuebler, welcome to the show.
Thank you.
Well, great. We were talking with Dr. Tim earlier about all things kind of chronic disease management and palliative care. You've had the kind of pleasure of being both on the chronic side as well as working extensively in the pain management side. Do you think that, what's your opinion on pain management as it relates to palliative care, chronic disease management? A lot of times we don't, even though pain is a chronic condition, we don't really classify it as that, sometimes both from the clinician side as well as the physician side. Do you think we should be talking about pain in relation more to chronic care? And do you think it intersects with palliative care?
Absolutely. I think that palliative care is basically symptom management. And if we look at patients that have multiple chronic conditions, or those that have 2 or more conditions at the same time, which is 3 out of 4 Medicare beneficiaries,
Yeah.
They have concomitant arthritis, they have concomitant low back pain. I just wrote a paper on low back pain, and the statistics are that 80% of adults will have low back pain at some point in their life.
Right.
So we know that if pain isn't appropriately managed, that will continue for a long period of time and eventually becomes chronic and is part and partial with other chronic conditions. So yeah, it fits in. And palliative care is symptom management. So palliative care is managing the pain that is affected by these underlying conditions.
So a lot of times palliative care and hospice are kind of used interchangeably. And when people think, oh, I should talk to, a palliative care, physician, they think of dying, right? And Dr. Tim talked a little bit earlier of, it's about quality of life, not quantity of life. And, you should have those conversations when you're ready to have those conversations. As we looked at that in conjunction with pain, what types of patients should, have those conversations with palliative care, as we have, increase in opioids and, depending upon states, and things like that, or people are having different types of surgeries to kind of prolong or help alleviate 30% of back pain or whatever it may be. When's that intersect that those conversations should, happen?
Well, that's a big question.
I know. I like big questions. So you can break it down if it's easier.
Palliative care is very different than hospice care. And I've been in the field for almost 3 decades now. And all of my work is to separate palliative care from hospice care, because palliative care should actually be integrated into chronic disease management the minute somebody's diagnosed with a chronic condition: heart failure, chronic obstructive pulmonary disease, kidney disease, chronic arthritis or low back pain or failed back surgeries. All of those give an opportunity for palliative care to increase the symptoms, or increase the management of symptoms rather.
Right.
And palliative care is evidence-based. And if we look at the origin of where both palliative care and hospice came from, they came from very different places. Palliative care came from McGill University, a very strong research-based practice by physicians, and hospice came from social work origin in England. So palliative care actually increases in its intensity as the patient begins to decline and become debilitated. So everything that I promote and write about is that palliative care actually helps to maintain physical functioning. If we can maintain physical functioning, that is the number one indicator of quality of life. And if patients are physically active and become less debilitated, they're going to have a better quality of life. But if they're symptomatic, they're going to end up in the hospital, they're going to become more debilitated, they're going to have increased pain and reductions in physical functioning, and it becomes a downward spiral. So I look at palliative care as almost preventative medicine. It prevents patients from going into hospital if you're proactive in managing those symptoms that prevent them from carrying out their activities of daily living.
And as we look at, I think that's a great explanation, and that echoes a lot of, what Dr. Tim was talking about earlier. And as we look at pain, because it is such a big issue in America right now, it's such a big issue in older generations and blue collar, and it hits every kind of class, right? We talk a lot about prescription opioids on the show, and we won't go too far down that rabbit hole, but as we look at pain as a whole, you've got the spinal stimulators, you've got, all the new epidural nerve blockings, you've got all these things that pain docs are trying to get folks off the opioids. And depending on who you talk to, there's probably two opinions by provider to every coin here on prolonging kind of pain. When does it make sense? I mean, is for somebody that's actively in pain management to talk to a palliative care doctor? Is it they've exhausted a lot of these new procedures? Is it the opioid side? Like, where would you suggest in that journey that kind of pain and palliative intersects?
Again, I think that palliative care is pain management, and it really belongs in the primary care setting. It goes hand in hand with managing chronic conditions. I see patients every day in the spinal intervention world. That's what I do. I take care of patients' pain every day, and we do it successfully without opiates. There's certainly room for opiates. Somebody has surgery, or they got malignancies, or they're in acute situation. But, so much has gone into new guidelines and new data and new research, and almost every federal agency under the U.S. Department of Health and Human Services has contributed to new information about why we don't need to use opiates. And what's interesting for me is to have watched the whole pendulum shift, from being aggressive with opiates. I was a pain fellow at May Day pain fellow at Sloan Kettering, but to see aggressive use of opiates, why aren't we using them, to now, why are we using them?
Yep.
And the data suggests that, other medications, which we call adjuvant medications, actually work just as well, if not better, than opiates. So I always tell patients, if we look at inflammation, for an example, that's one of the biggest indicators of pain. I can throw all the opiates and muscle relaxers and central nervous system stimulating drugs at that all day. It's not going to take care of it. The anti-inflammatories or the corticosteroids are the medicines that would take care of the inflammation. Somebody has nerve pain. No amount of opiate in and of itself is ever going to take care of nerve pain.
Yeah.
There's other medications, antidepressants, anticonvulsants that we can use that are indicated to manage nerve pain. And spinal interventions work amazing. And I see all of those things as palliative. I see my job, even though I'm not taking care of people that are terminally ill and dying, but they have chronic pain, I see my job as a palliative provider managing their pain from a spinal intervention perspective.
Yeah, no, that makes a lot of sense. And so now that, we've got the silver tsunami, we have a lot of seniors aging, wanting to age at home with multiple, chronic diseases, and that management becomes a little more complex as you have specialty docs in the mix, as you have primary care, as you have all these kind of things going on. As we look at the future of where kind of palliative is headed, a lot of palliative and as well as hospice are really looking at, extending that virtual care into the home and how to have better patient outcomes and not have the windshield time of the palliative care providers, driving home to home, facility to facility, things of that nature. So now with remote patient monitoring, with telehealth, with things like that, where do you see, if we roll the tape and, we're talking in 5 years from now, where do you see the palliative care providers being able to extend and have, changing condition, on the hospice side, or more proactive chronic care on the palliative side? Where do you see kind of that mix headed with kind of where we are with seniors, caregivers, and where that's all headed?
Yeah, absolutely. Again, I see palliative care back in the primary care providers' responsibility. I don't think symptom management necessarily needs to be isolated from primary care. And as a patient traverses down the trajectory of disease, obviously they're going to get weaker and they're not going to be able to come into primary care clinic. But, in 2015, CMS developed the chronic care management incentive. So primary care providers who have patients that have more than 2 chronic diseases, they think they're going to die within a year, they're eligible for 24/7 constant monitoring by their primary care provider, and they get incentivized to do that. I think, what's unfortunate is most primary care providers are not familiar with this model and they're not utilizing it. And you can use that from remote. You can text the patient, you can call the patient, you can have telehealth with that patient and still get reimbursed, as well as get reimbursed with telehealth as well. I think, the whole patient empowerment, shared decision-making, patient self-management, engaging patients in their care, to identify early on symptoms that could take them into hospital, and communicating with their care team earlier than later will keep people at home, will keep them more physically active, will, obviously influence their improved quality of life, and, help them to do the things that are important to them before they're, not able to get out of bed.
Right. No, that's great. And so the last question, we talked about this earlier in the show, and I'd like to get your opinion as well. We talked a lot about exactly what you said, kind of the quality of life versus quantity of life. And a lot of times, patients are used to listening to their provider, the white coat, respecting that. That's kind of the generation they came from, is you do whatever the doctor says to do. But a lot of times there isn't those honest conversations, as Dr. Tim was talking about earlier, to say, do you want to start chemo on Tuesday or Thursday? It's not, hey, this is how you're going to feel through chemo, and you could live, 5 years, or you could live X number of years with no, quantity versus quality of life. Do you feel like that's changing and there's more honest conversations, or everyone's kind of afraid to have those conversations, or where are you on where you think that is today?
Well, I think it's interesting with the onset of the Affordable Care Act. If we look at some of the agencies that were created out of that, the Patient-Centered Outcomes Research Institute, or PCORI, everything is patient-centered, and patients are actually participating in the research designs and contributing to ideas about what should be funded. All of the resources that have gone into what I just mentioned before, shared decision-making, patient self-management, patients being engaged, looking at literacy levels, all of those things focusing specifically on the patient, is a big shift in what we've seen in the past. And this whole macro legislation, where providers have to actually quantify what it is that they're doing to determine whether or not they get incentive reimbursement in their practice. So I think we're looking at changing that. I'm having a conference, a national conference this fall, and we have half a day developed or designated to pain, and we're approaching it from, it takes a village to take care of a pain patient, right? It takes a doctor, it takes a nurse, it takes a social worker, it takes a spiritual advisor, it takes a chiropractor. Sometimes it takes an attorney or a physical therapist. I mean, it takes a whole team of people to take care of one patient to make sure that they get where they're supposed to be. And if we look at the true meaning of palliative care, it is a team approach to making sure that that patient has everything that they need.
No, I think that's great. And so the one thing we always ask at the end of the show is, what is one thing healthcare related that is keeping you up at night?
Well, the thing that I write about a lot is, I think one of the biggest things, and all of us that are in healthcare, I'm sure, see it from time to time, is anecdotal practice. Not implementing the best evidence, not staying current with the current guidelines, not making sure that the patients are getting the most current interventions, or, I see, we don't recommend aspirin routinely anymore. There's a big thing on vitamin D and fish oil and all these things that, we have to stay on top of in order to make sure that the patients are getting the best care. I was really surprised in 2016 when the CDC announced unintentional death as the third leading cause of death in the United States. The majority of it comes from opiate prescribing, but we're responsible as healthcare providers to be making sure that we're using the best information to guide optimal patient care, particularly in the fragile patient population.
Well, that's great. It has been so great having you on the show today. I want to thank both of our guests for being on the show today. We had great conversations on chronic disease management and palliative care. Please click on the link in the show notes to follow either of our guests today and ask any questions. As always, make sure you subscribe to the show to get it delivered to your player of choice on Tuesday and Thursday. Thank you so much again for being on the show. You were great today.
Thank you.
This podcast has come to a close. To hear more from the Executive Innovation Show podcast, subscribe, submit questions, and share the love. Follow us on social. We're everywhere.